All right. So welcome to our third live World Delirium Awareness Day session. For this session, we are focusing on what it is actually like to have delirium from those who have experienced it. The lived experience is critical, I feel, to understanding delirium and making progress. And full disclosure, this session is being recorded and it will be uploaded to the iDelirium YouTube channel to be shared for everyone who wasn't able to tune in to our live event. My name is Heidi Lindroth. My vision is a world without delirium. I pretty much do anything I can to move the needle towards that vision. And I'm a nurse scientist and medical ICU bedside nurse at Mayo Clinic in Rochester, Minnesota. I feel very, very, very honored to be joined by these fellow delirium, I'm not a delirium survivor, but these delirium survivors. Mark Hudson is a delirium survivor and ICU survivor, is leading us today in this session, and he's joined by Lou, Gallie, and Rebecca. And the format for this is largely informal. They're going to share their experiences. If you want to ask a question in the middle of the experiences, please put it in the chat box or raise your hand. Afterwards, there's going to be a lot of opportunities for questions. So I truly am honored to be here. Thank you so much for doing this for World Delirium Awareness Day. And Mark, take it from here.
Hi, thanks, Heidi. I'll just explain the format very quickly. So we're going to have 3 separate videos, one from myself, one from Louise, and one from Rebecca, explaining our experience. And it will be about 23 minutes in length. And then after that, there'll be time for questions and answers. So I was just going to screen share and get started. So as Heidi said, if you have any questions, put them in the chat and one of us or all of us will answer if we can. So thank you for attending and I hope that you enjoy it. Hi, my name is Mark Hudson and I am a former delirium sufferer. I have experienced 2 incidences of delirium. One, like my fellow panel members, was in ICU, and another was due to an infection. My first encounter with delirium was in 2015 when I was in ICU for 3 weeks at the end of December into the start of January of 2016. My delirium experience in ICU involved being tortured by the staff, being cut open and left to bleed out, being waterboarded, being assaulted, restrained. Interspaced with them were times where I was managed to escape, but even when I escaped, I still had the feeling of being hunted down, and I was eventually caught, brought back, and then the cycle of torture happened again. I had my neck cut open, which in hindsight reconciles with the time that I had central lines placed in. My wrists were cut, which probably coincided with times when I had arterial lines placed. The feeling of being waterboarded and drowned probably coincided with the fact that I had ARDS and my lungs were filling with fluid. There was times where I felt like I was being put in a freezer to freeze to death. This probably was a time when my temperature was extremely high and they were trying to cool me down. So from this ICU experience, I think it quite clearly shows that the actions of the staff have effect on the delirium. So the sort of unknown stimuli, so I was detached from reality, unable to perceive reality. So my body and my brain created a narrative for the experiences it was feeling. I was having my neck cut because I was having my neck cut for essentially for central lines to be placed. My wrists were being cut because they were placing arterial lines cutting into my skin. So although the delirium experience was extremely traumatic, and I felt that when I woke up from my delirium experience, that I felt that 7 years had passed. So for 7 years, I had been systematically tortured daily. And I'm sure you could understand that if that happened to someone in reality, they would have extreme mental health complications. They would have PTSD, anxiety, depression, all of which I had. So although the delirium experience was not real and that it didn't happen in the real world, it is very much real to the patient, because the thing that tells you what is reality and what is not is the brain. And when the brain is dysfunctional, as it is in delirium, there's no way to discern between reality and fiction. And so that's why the effects of delirium are so traumatic and so prolonged. Even 5 years on, I'm still having cognitive and focusing issues, still having anxiety. So my second meeting with delirium was last year. I had an abscess in my armpit that became septic. I became extremely unwell, running very high temperature. And while I was in, my NEWS2 score was 6 or 9. I can't remember. It was high and elevated, triggered for delirium. Things that I noticed, and it was a very different experience of delirium. I noticed that my thoughts were slowing down. My ability to comprehend a conversation and follow a conversation was difficult. I started speaking nonsense, and my sort of filter was no longer there. I also became slightly agitated and quicker to be angry, and I became quite lethargic as well. And because I've advocated for delirium for a long time, I knew what was happening. I knew the signs. I knew what they meant. So I tried to reorientate myself. I kept telling myself where I was. I kept telling myself what the time was. I kept looking at pictures of my family and telling myself who they were. I tried to get phone conversations, video calls with my family to reinforce this reorientation. I tried to move as much as I could, although I was isolated in a side room and unable to move much due to my immunodeficiency and the current COVID restrictions that apply. So I would say that the second incidence of delirium was far different from my first. My first was, as far as I'm aware, quite quick onsetting. I went from, having a semen infection to being in ICU in a very short period of time. And that very 0 to 100 nature of the illness meant that the delirium seemed to be worse, obviously, as well as the sedation and other medications that are given to you in ICU probably muddied the waters in terms of my brain more, and so made the delirium worse. But the thing that I take from my second experience is that early intervention really does work. I was able to bring myself mostly out of the clouded state. So just prior to me going down to surgery to get my wound drained, I felt that my thought process was almost back to normal. It was speeding up. I was more able to engage in the conversation, understand what was going on, and be fully cognizant of what was being said and remember what was being said. And I think if that reorientation hadn't happened and I had have went down to surgery being sedated, I think I would have came out of that surgery with a much worse case of delirium. So this is my story, and after the other two speakers, Louise and Rebecca, have spoke, we will be happy to answer any questions that you have on any of our talks or anything about the delirium experience. Thank you very much. I hope you enjoyed. Hi, just 2 seconds and I will queue up the next video.
Hi, I'm Louise and I'm here to tell you about my ICU delirium experience. Now, I'm a patient at University Hospitals in Plymouth and I have a rare condition called achalasia. There's no cure, but there are palliative options available, and in November 2018, I had elective surgery to help ease the problems with my swallowing. And that is my last memory. 48 hours later, I became critically unwell, and it was discovered that my esophagus had ruptured and sepsis had set in. Although I don't remember what happened, I do remember sensations of incredible crippling pain. And I now understand that I only had hours to live. I was rushed to theatre for life-saving surgery and was placed into a medically induced coma. My family were told that if I made it through the night, I might stand a chance of surviving. And the battle was down to my body and me, and thankfully I did survive. Now, of course, I knew nothing about what was happening. My last memory was of me walking down to theatre for the original procedure, and my next memory would be waking 2 weeks later. So instead, I found myself in a strange, terrifying world. This was my reality, and despite what was going on in the physical world, this was happening and it was real. I experienced severe ICU delirium. In a period of time that felt like years, I experienced torture, abuse, physical harm, harassment, hallucinations, and quite frankly, nothing at all pleasant. Some of my experiences included finding myself as a soldier in World War II, in an underwater Olympic swimming facility, on the deck of a naval training platform, in a virtual reality world, in a hospital under attack, in a theatre production of a macabre Victorian play, at a disused train station, in an Irish convent with evil nuns, in a riot, and many, many more visions and recollections. Within each episode, which to this day I still very much believe to be real, I could see, smell, hear, taste, and touch everything. I could hear the sarcasm in the nurses' laughter when they mocked me. I could feel the nun carving a picture of Jesus into my arm and her hands in my wounds. I could see her staring at me night after night. I could hear the gangs of hyena-like teenagers setting fire to cars outside my window. I could see the water in the underground swimming pool, and I could smell the toast being made by the nuns, and I can remember every single detail. It's important to remember that this was an alternate reality for me. These things weren't happening, or at least not as I knew them to be, and I'll explain more about that in a moment. But during my time in delirium. They were very, very real. I was in a relentless state of confusion, anxiety, under threats from anyone who came near me. And I was left for dead, humiliated, abandoned, and there was no end to the unrelenting cycle. So some of my delirium experiences can be related to things that actually happened. With the help of my ICU diary, which the staff wrote in every day, with the help of the ICU psychologist and the rehab team, I've been able to make sense of a few things. For example, the picture of Jesus being carved onto my arm was in fact caused by a surgeon struggling to insert an arterial line into my arm and the bruising that appeared after. Now, this would suggest to me that this scenario must have occurred after extubation, because I obviously looked at my arm and saw something completely different. Therefore, perhaps suggesting that I had some awareness, but that awareness was distorted by the delirium. The nun staring at me night after night, whose features I can describe so vividly, was actually a nurse who spent one night's shift looking after me. Not staring at me, but monitoring me. And when I described her features to the rehab team, they knew exactly who I was talking about. Whilst in the convent, I would hear what I thought were ambulances driving up a hill outside. They made a strange whining noise that got higher in pitch as it moved. This was actually, we believe, a mobile X-ray machine being brought onto the unit. One day, when I was at psychology appointments, one of these machines came past me, being pushed by a radiographer, and I flipped out completely. But luckily, with the help of the psychologist, I was able to understand that this was the noise I kept hearing in ICU, and it wasn't a strange Irish ambulance. What fascinates me is how the brain processes everything. Although it's sometimes possible to give explanations to some deliriums, to others it's not. I personally believe that it was my body and brain's way of coping. Its way of trying to understand everything that was going on between the pain and the trauma and the drugs and everything going on around me. It intrigues me how I could and still can picture everything in such detail. I can see the ornate wood panelling on the walls of the convents, the tower blocks and the police cars outside the hospital, what the teenagers in the riots were wearing, what World War II smelt like. I can even tell you the type of gravel that was on the footpath. After 13 days in ICU and 10 days in a coma, it took a further 7 days from step down to the ward before I began thinking more clearly and before the deliriums began to end. It was during this time that I was able to start thinking about what had happened. During the transfer from ICU to the ward, nobody explained to me about delirium and how it might impact on the next stage of my journey. My first night on the ward was horrific, and I must have been a horrible patient to deal with. But when my mum arrived the next morning, I remember asking a student nurse in the riots and what the riots were about and the hospital lockdown. And he looked at me with some confusion, but went to find evidence of this happening. When he returned, he was even more confused, but confirmed that none of this had happened. I was adamant that it had, and it was at this point that I remember thinking to myself, what the hell has been going on? But more importantly, at no point during my 3 months to stay did anyone talk to me or my family about delirium, about what it was, how it affected me, and importantly, how it might affect me moving forward. During the rest of my time in hospital, I didn't think about the visions I'd experienced because I was too occupied with surviving and recovering. It was 6 weeks after discharge when I began spiraling out of control with panic attacks, flashbacks, reoccurring memories, thoughts of wishing I died in ICU, becoming emotionally numb, all the classic signs of PTSD. PTSD is crippling, and very few patients are made aware that they might experience it after discharge, maybe at some point in the future. I was very lucky to be signposted to the ICU psychologist at Plymouth, and they're only one of very few in the UK who offer this service. Through EMDR and other treatments, she has helped me to understand and overcome the deliriums. And although PTSD sits on my shoulder like a little goblin waiting to strike, I'm now in a place where I can talk about what happened and help others. To this day, I still don't understand how a stay in ICU can cause such psychological upheaval. You're welcome to visit my blog to read more about my journey. It's from delirium2reality.com. And thank you for watching, and I'm happy to take any questions you might have.
Good afternoon. My name is Rebecca Langley and I was in intensive care in 2017. I had a different delirium experience from the others that you've heard today. I have no recollection at all of the time while I was sedated, and the memories of the few days prior to going into sedation in intensive care are very few and patchy. It was like my memory had been wiped completely. A black, not a scary black, like when you sleep, but without dreams. I didn't experience delirium until after the attempts to wake me from sedation. My first memories are of the a loud hissing noise and the staff and my family telling me not to pull my oxygen tube out. At this point, I had no idea where I was, what had happened, or had any recollection of the events of the past few months. For me, it was like I'd been dropped in a foreign land with amnesia. It's very difficult to describe. There was no concept of being in hospital. I wasn't in a place, I just existed. The hospital bed and various machines didn't exist in my mind. I was there, but I had no idea where there was. My family and the staff were there, but I couldn't see them. I could sense them. It was like an illusion, I suppose. Strange as it sounds, at this point, it wasn't scary. Strange or confusing, illogical, but not scary. The logical part of my brain wasn't working and I saw nothing in context. It really fascinates me now, looking back, how the brain protects itself from the overwhelming knowledge of the truth. I was completely unaware of the outside world and my memory had been wiped. I had forgotten all about my cancer diagnosis, my stoma surgery and having a stoma. Apparently, I asked my family what my stoma bag was, and when they told me that it was because I'd had bowel cancer, I said that it was very rude of the doctors not to tell me that I had cancer. I saw nothing in context and everything was very, very bitty. It's a bit like a jigsaw puzzle with big gaps and it just didn't add up. My family tell me that I repeatedly asked when I would be allowed to go home. They said that it would be a while and I responded that, okay, well, I'll cycle home then. When they told me that the nurses wouldn't approve of that, I said, okay, I'll get a taxi. I genuinely meant those answers and my brain just could not comprehend how ill I was. Intensive care for me was experienced through audible and illusions, whereas high dependency was much more visual experience. When I was moved to high dependency, I could see things. I hadn't done that before. That wasn't possible for me in intensive care. But things were distorted. It isn't how I see now, and certainly when I went back to visit intensive care, it looked very, very different to how I remember it lying flat at 3 foot. Doctors standing over the end of my bed towered over me, but they could have been giants for all I know. At night, I often like to think and imagine that I was on the International Space Station, and at least took the pain and eased the trauma of the experience. All of the main lights switched off, but the screens and monitors on, and the staff watching them and us, and monitoring us and keeping us safe, as you would on any space mission, looking after your crew. Confusion, delirium, and amnesia seemed to overrule logic, sense, and connection. Was it the strength of the drugs that I was on? I don't know. Was it the pain that I was in? I don't know. I will never know. But I hope that in us talking today and raising awareness of delirium experiences, that more can be done to reduce and hopefully prevent delirium in the long term. Thank you.
So thank you, Louise and Rebecca, for sharing your experience. Heidi has the question in the chat. So Heidi has asked, what do you think would have helped you during your ICU stay to decrease the delirium you experienced? So do either one of you want to start on that?
I don't know how to answer that. I always struggle when somebody asks me that. I never know what to say because I just simply don't know. Thinking of it purely from a patient perspective, I was just so out of it in a different world. I don't know what would have helped me. Looking back on it and knowing what I know now, I don't know. I'm very lucky that the staff where I was did everything they could anyway. So they spoke to me. We had orientation boards. They brought in my belongings, my family. Obviously very different to how it is at the moment. But I think they did everything they could. So I don't think that anything could have prevented it, because I think it was infection, it was drugs. But I don't know. I think really just being human, just understanding that the person in the bed is a human being. And although they might not be able to communicate with you in a normal sense, they can probably still understand what you're saying. And although their brain might not interpret it in the way that what you're saying, there's still an awareness. So I remember somebody sitting with me, holding my hand and just really calming me down. Now that's sort of merged between reality and a delirium, but I still very much remember it. And I remember being very anxious to them feeling very calm, because somebody just sat with me and just held my hands, and that was enough. So I don't know. I'm not a healthcare professional. I don't know the ins and outs of delirium, if you like, but I think it's just a real case by case basis. Take each person in as an individual, but remember that they are a human being, and just to comfort them, just to make sure that they know they're safe and that they know where they are, and that what they're experiencing in their heads isn't actually what is going on in the real world, if that makes sense.
Yeah, so I kind of feel I have a sort of answer to this, because there was, in my delirium, there was most of the staff were the bad guys. They were the villain of the story, except from one nurse, Quentin, who is world renowned in our ICU, and that every patient remembers Quentin. Might not remember anybody else, but they'll remember Quentin, because Quentin, from what I'm told, because I was not really fully aware when I was in ICU, was that everything he did, he spoke to the patient, he told them what was doing, told what was happening, told them why he was doing it, and just spoke to them like he would speak if they were fully aware and awake. And he was the only person in the entire narrative of my delirium that wasn't a bad guy. He helped me escape. He helped me get out of the torture area I was in. So I certainly think there is a clear benefit to speaking to the person like they're a human. Rebecca, do you have anything to add?
I'm not sure if anything would have helped at the time. So mine was coming out of the coma rather than in the coma. And the staff spoke to me. It was a time when family were allowed in, so they spoke to me, and I don't think anything would have changed that confusion, that lack of understanding, not having a clue what was going on or what had happened or where I was, or not understanding what was wrong with me. You know, oh, I'm going to cycle home. Well, I don't think I even knew what a bike was, let alone being able to get on one and cycle. But I think in recovery, I was in intensive care in 2017, and at the time the unit didn't have intensive care diaries, and certainly Lou, I've seen the difference in her recovery in understanding specific experiences. And I just wish my family kept some notes, and it explains some of my confusions and to specific events. But I think it would be really, really interesting if I had that delirium diary. And I've looked at my hospital notes, and that makes a bit more sense. It's very, very clinical. So I think it's a more human approach with the diary, and I believe a lot more intensive care units use that now, and there's huge, huge benefits. So I'm not sure at the time if there'd been any changes, because the staff and the nurses and the family were talking to me. I think in my recovery, maybe a diary would help me understand my experience and you know, specific occasions of strange events that we misunderstood, and put that into context.
Yeah, my department didn't have ICU diaries at the time either, so I was working off of notes my mum had. They do make a huge difference, as I've seen through the recovery programs, but I've obviously had an experience of delirium that isn't ICU delirium like yourselves, so I was much more aware of kind of slipping into delirium, and I think that if someone had have noticed because I noticed I had a clear change in character and a clear change in mood, and if that had been caught and I hadn't had to reorientate myself, if someone had been facilitating that, I think I would have been better off. So I hope that kind of answers the question, Heidi. I see Alistair's joined as well.
It's really helpful, because I think as a clinician, it's like you really want to help, and I think as a scientist, I'm always focused on prevention, and I realize I'm new to the medical ICU. That's not prevention isn't, like Alistair's been saying, and we've been talking about the last few days, like it's really about treatment and reduction and stopping that severity and duration. And so I think it's just, for me, it's really helpful to hear from your experiences what would have helped, and this is super helpful. So thank you for sharing.
Yep, Alistair, yep.
Well, thank you all. I mean, I find these things always very emotive, you know, and even though I've heard stories with some overlap with every story is unique, you know, but there's obviously some common themes. And like I was talking the other day about a colleague who had terrible ICU delirium. I've already told Mark and Heidi about this, but she and I did a presentation together for her hospital, and she was talking about how, you know, how terrifying it was, and the mood side of delirium, which is not emphasized very much. You know, in the diagnostic side, we're just told to look for changes in attention and fluctuation and quite cold things, really cold parameters of mental functioning, not really what is it like for this person. And I think that's got a cost, you know, the fact that the diagnostic criteria are quite, you know, to do with cognition and not with mood or fear, you know, or psychosis. And she said, I mean, it's, you know, it was very emotional at the time when she was talking about it, but she was saying that she was in ICU for a month or something like that, and was, you know, very frightened the whole way through. She couldn't speak, even when she was extubated, because her brain just didn't work. You know, she couldn't say things that she wanted to say because it wasn't functioning. And she could hear some of the things around her, but couldn't respond to them. And she sort of knew that her brain wasn't working properly, but it wasn't quite enough to overcome the fear and all that. But she said she was getting taken to have a CT scan, and she was terrified on it, you know, being wheeled along. And a porter noticed that she was extremely frightened and held her hand and reassured her and told her she was going to be all right, love. You know, I know you're having a nightmare, but you know, you're going to get better soon. Don't worry, it's going to be okay. And she said that that was the moment in the whole 4 weeks that meant the most to her. And she said if she won the lottery, she'd give all the winnings to this porter, because that moment was like a shaft of light, you know. And I found that story extremely influential, you know, in my own practice. I only heard it like about a year ago, but and just, you know, even, I mean, I've worked mainly with older people, and you know, probably the hyperactivity is maybe a bit less common than in you know, in younger patients with delirium or people in ICUs, but it's still there. Even if there's no hyperactivity, just what you're saying, Mark, about the guy that was the legend, you know, just the talking and the smiling. I mean, we can't smile so much now because of masks, but you know, when we're allowed to just have normal without masks, and just being nice to people and explaining what was going on. And my friend also said that she found that simplicity and just being told what was going on was extremely valuable. And that's been said, you know, by I think at least 2 of you today. So I just wonder whether, you know, I mean, I'm not involved directly in the EDA anymore, but I just wonder whether we need to be more proactive about teaching clinicians how to talk to people with delirium. You know, like I'm thinking about some kind of training package, you know, that would be hosted by one of the big societies. Because why should we have to keep hearing this for it to be just, it should just be routine, shouldn't it, you know? And Mark's very powerful words about, you know, it's a, you know, remember, and somebody else said that as well, it's a human being, you know, it's a person just like you know, who's going through the worst nightmare of their life, probably. They need your help, you know. And I think, but we forget that. We're probably desensitized a bit, and it's kind of shocking that this is news still. You know what I mean? Like, why is it news? And of course, we've got social media now. We've got ways of disseminating this much better than we had before. But it used to be like quite rare information, patient experience, you know. And somebody would come to a conference, and everyone would be like, you know, oh my God, that sounds terrible. And do you know what I mean? And then, you know, a few people would, you know, it would make a big difference. But it just seems like it's quite rare still to have this kind of event. So, I mean, this thing, this recording now will be on YouTube. But I'm thinking, you know, I mean, Mark's very active, and I know I've not met Louise or Rebecca before, but I know you, that you are active as well in sharing your experiences. But I just wonder whether, I don't know what you think, Heidi, you know, with ADS on, you know, that it'd be nice just to have this, depending on who would be prepared to put their face forward, because it's obviously quite personal and all that. But you know, just to sort of have this as a running thing, you know, like, you know, we just tweet about it often, so people often see it, and it's considered a normal part of delirium training, that, you know, you listen to some of these stories, and because I think most people are quite kind, and if they hear it, it'll etch into their mind, and they'll be reminded, and they'll just behave better. It's not that they want to behave badly, they just don't know.
Right.
You know,
I know, I
and it's
think,
just it's a working day. You know, it's a working day. There's problems to be solved. There's people who are having a rough time, but that's the same as it's been for the last 25 years. Like, you know what I mean? And you almost need to be reminded all the time about how bad it might be for that new person, because to them it's new. You know what I mean?
mhm. I completely agree. Go for it, Lou.
No, I just I agree. I vaguely, very vaguely remember a consultant coming to see me in ICU a couple of days after I'd woken up from the coma, and I remember him talking to me about what was going on, but I have no idea what he said because I didn't take any of it in. And I remember him walking away, and his colleague, I think might have been a trainee, like a trainee doctor or something. And I don't know why this stuck in my head, but I remember him asking the consultant why I was sort of in sort of like a spaced out way that I was. And the consultant almost made a joke of it and just said, oh, she's not quite with us, and she's just a little confused, and you know, and it just made me feel I couldn't do anything, I couldn't move or anything, but I just really inside I was screaming because he had no idea. He just saw me as a number effectively. There was no understanding of the delirium, and I don't know whether that's just the way he was or whether that's just the way it is. I don't know, but there were a few occasions where I was definitely spoken to as though I'd lost the plot effectively, and that I was sort of being like that rather than something making me like that. So I think it would be good to put something in, some sort of training to sort of, yeah, I don't know how you teach someone to sort of work with someone who's got delirium, but I think there needs to be something, because as what's been said, we're still talking about it, and this is still relatively new to me, and it just keeps coming up time and time again.
Mm-hmm.
Yeah.
One thing I was going to say is that it might reduce the stigma. So I had no idea that what I'd experienced was delirium. And when I went to the 3-month follow-up clinic, the consultant wrote, Rebecca experienced delirium, and I remember hiding it in amongst my, you know, what's wrong with me, you know. And I didn't speak to anybody for ages because I was so ashamed of this. I thought, you know, I was out of my mind, or there was something psychologically wrong, and I didn't discuss it. And so maybe raising the awareness will hide the shame. You know, I'm terrified for the patients that have experienced ICU in the last year, where they haven't had their families in, where they've had lower staffing ratios, where they've had the staff in full PPE. I mean, it was terrifying enough when you've got your family and the nurses around you, but to have all of that as well, the delirium stories that are going to be present, you know, and they're going to come out in the next few months is terrifying. And a lot of people won't want to talk about it, won't want to discuss it. And I think the more that we can talk about it and raise awareness that, you know, there is no shame. It's part of, well, it is a possibility of being critically ill, or as Mark said, you know, an infection. It doesn't have to be ICU related. But yeah, I think you know, the word delirium can be quite a label without the knowledge that, you know, I've now picked up and still learning about.
So I would say my experience is slightly different. Obviously, delirium was never mentioned at all in my stay, and was sort of, I don't want to say casually thrown in, but sort of off the cuff mentioned in my ICU rehab. But having had as much wrong with me as I've had, it never was stigmatized to me. It was just another thing to add to Mark's pile of woes. So yeah, I didn't feel that way, but I don't know if that's just I've been knocked down enough that I'm just numb to things now. I had a question that I wanted to wheel round. Do you think, and this goes to MD that wants to answer that, do we think that delirium needs follow-up specifically? So ICU has follow-up, but do we think a delirium follow-up would be a useful thing to track like the after effects of people that have maybe had it post-surgery, post-infection, and the kind of effects like anxiety, depression, PTSD that can accompany having had delirium. Would it be a useful thing to be caught earlier, maybe? Or I'm really aiming at Alistair with this question, but if Rebecca or Lou have an opinion on it, then I would love to hear it.
Well, I think, I mean, in the SIGN guidelines, we do recommend that there's delirium follow-up. Without it really, we had a lot of discussion about it at the meeting, and there were patient representatives there. And I think there was some disagreement about how that, what form that should take, because some people thought, well, many people still don't have this kind of experience. They're just sleepy for a while and they don't remember it, especially older people, maybe with cognitive impairment, and it doesn't leave a scar that they're aware of. They may have a biological scar in the sense that their brain's been hurt at the time of their delirium, and that can have a legacy for them, but they wouldn't know what the follow-up clinic was about, some of these people. So I think it was thought that it was a good idea in principle, but that how, given the volume of people with delirium in hospital, how it would be arranged and how you would select people who need it was more difficult, and it was something to be worked on rather than to do routinely. I think what was seen as really important was diagnosing delirium using the word and passing that to the GP, so that at least, that's a bit of an open door, and to advise people to go and see the GP if they feel bad after. I mean, that's very rudimentary, and a lot of GPs, wouldn't necessarily be aware of a hospital doing that, giving that advice. But then I've read many GP notes where GPs are fully aware of the costs of delirium, the long-term costs, and the fear that people can be left with, and would deal with that sympathetically and refer on to psychiatry if required. Like a lot of things in delirium, it's to do with just this basic level of education. It's like living in a world where some people know how to farm efficiently and do it, and everyone gets fed quite well, and the land is looked after properly, and it's sustainable. But that knowledge hasn't reached quite a lot of the rest of the world, and so people are farming in a really inefficient way, and there's lots of diseases, and things go wrong. It's kind of like that to me. Like a lot of the basics of delirium are there. We don't need to, and it's not like it. I mean, there's lots to be done research-wise, but there's a lot of basic stuff that is now known, and there are pockets of great practice, around, like follow-up ICU clinics in Glasgow, which has won awards, and in other ICUs where they, we see massive variability in care as well. I mean, I don't know if I can show you this on my board in my room.
You'll need to take your background off, Alistair.
Yeah, it might be too complicated, but I'll just read it out. I'll just see what it says. Just so I've got a kind of whiteboard to write down scribblings, and one of them says, with highly variable care, highly variable outcomes and survival. And that's one of the problems that we've got, is just that the variability of care is so dramatic in delirium, isn't it? Like from the people that sit beside the bed and say, how are you doing? Mark, I know you're having a shocking time. You don't feel well, and you might not be feeling like your normal self, but we're here all day and all night. Please tell us if anything, we can help with anything. I'll just go through, and I try and do it with my patient. I tell them, you had your hip fracture, you had a fall at home, you broke your hip, you had your operation 2 days ago. It was really successful. There's nothing wrong with the wound. You're making a good recovery, but you're still not quite yourself because the drugs we're giving you for pain. And every day the physios will come and see you, and gradually you're just going to get walking again, and we'll get you home. And often it makes quite a big difference to somebody just to have someone tell. I mean, how long did that take? 30 seconds, but why is that just not what bothers me is there's the variability, the lack of that being standard. And it's interesting what you were saying, Louise, about how would you train somebody? That's a great question, because people get trained, people in mental health services and nursing get trained in de-escalation, so they go through a day of training for that, to calm people down, to stop the threat of violence if somebody's usually because they're frightened, but there are real risks to healthcare professionals, and that's why drugs are sometimes used, to sedate people when maybe it'd be better to avoid them sometimes. But it's counselling. It's a kind of counselling, isn't it? How to do counselling with somebody who's in the middle of delirium. And maybe there should be training on that, given that a quarter of patients in hospital have delirium, a quarter of all patients and half of ICU patients, we should all be trained in how to do delirium counselling. And obviously it's not going to be one size fits all. Sometimes it's going to be repeated visits with calming somebody down. Other times it's going to be one visit or two and somebody seems to be completely fine and they're getting better quickly and that's it. I don't know what you think, but I mean, I don't want to be facile about it. I mean, it's going to take work and effort, but there's Dorothy Wade, who's just published this article in The Guardian today or a couple of days ago, highlighting ICU delirium. It's worth looking that up, but there's expertise around, isn't there? I mean, Heidi's work day to day with patients in ICU as a nurse. So it's, every day you're learning, aren't you? Kind of like that's just as I still keep learning every day about, delirium and then we've got all, people like yourselves who are just shedding so much light on your experience. So I think we should make this a formal thing. I think we should propose it to the societies and put some resources into it, because I'm aiming to set up a website called thinkdelirium.com. We had a sort of abortive attempt a couple of years ago, but it takes a lot of time to set up a website, but I really want to make that a kind of good hub for delirium education. But I think make training courses, and we could learn from you, like what would work, what kinds of things would work. Be really helpful, I think. I think many people would just lap it up because a lot of doctors and nurses are uncertain, and they want to help, but they just don't know how to, so I don't know. What do you think about
that? So I'm going to wheel the question round to something that's asked in chat, which is a bit linked as well. So we had a conversation there about delirium simulation and using that as a communicating learning tool with someone that has delirium. Now I've witnessed a delirium simulation by Dr. Morden and Vicky McCrae at the EDA training day. And I think it's very useful. I think it was done very well and sort of very true to kind of my vague recollections at that point. But I feel that it's very easy to simulate the very over agitated hyperactive, but it's not so easy to do the hypoactive. And I feel that any simulation done in delirium, and feel free to chip in, Rebecca or Louise, if you have anything to say here, but I think that needs to heavily involve delirium patients, because it's easy to act, but you have to have the kind of understanding of why people are doing that. It's easy to be that obnoxious, loud person, but why are they being like that? I don't know what Rebecca or Louise feel on
Yeah, I think
simulation.
It's with anything, isn't it? A simulation is only going to come part way close to what it's really like. And I guess, yeah, it's for those who have been there, if you like, to give that extra knowledge. And as you said, sort of some of us, could be sort of really loud and rude and violent, and others can just be really quite quiet and withdrawn, but still be in that sort of scary place. I think somebody's put in the chat somewhere that it's about when you talk to somebody with delirium, that can take experience and knowledge, and I think that's right. I think even though I've been through it myself, I don't know if I'd be able to handle very well talking to someone with delirium without coming across as a little bit patronizing. I don't know. I'd want to reassure them and sort of, and make them sort of feel safe. But I don't know if I have enough knowledge of seeing lots of people in delirium to know how to sort of reassure them. If that makes sense.
I think it's about giving our experience to the clinicians who see it regularly, and sort of hybriding these two experiences together to form something that'll work and something that's true to the actual problem. Because I don't really want doctors learning how to deal with delirium on people that have delirium, which seems to be the case in a lot of circumstances, that people have learned how to work with delirium by being really bad at working with delirium until they got good.
Well, can I interject? And to be honest, I don't think there is much learning. You know, I think most people just don't see it as something to be learned. You know, it's something to be contained until the illness goes away and the patient gets better. You know, but they don't. I think that's something that I try and put in my Delirium 8, you know, thing, which is recognize and treat distress, you know, as a separate part of the delirium management, you know, because it's just missed. You know, I mean, people just, delirium treatment is taught. I mean, if you were to read most recent textbooks or review articles, you would see that mostly it's about treating the cause and doing the physiological care and using drugs for agitation, and actually a specific focus on, you know, somebody's distress is just not, it's just not that good. Delirium treatment, you know, I mean, I'll be honest, it's just not that good.
One thing I was going to say is it'd be amazing if it worked, but what intrigues me almost, or fascinates me, is that what does the outsider, what does the practitioner see compared to what we see as patients? So you two had very, very vivid, correct me for incorrect use of language, but, you know, hallucinations, whatever you want to call them. You know, you were in that world, that was your reality. But at the time, how can we train somebody to see that if all they see from the outside is you in a coma? Does that make sense? You know, so for me, I may have looked as though I fully understood where I was, what was going on, and I said, yeah, I'm going to cycle home, or I'm going to get a taxi, and actually they thought, yeah, she's doing all right. She's, you know, she's talking a bit of rubbish, but it's not that much rubbish, and her memory's rubbish. She's forgotten the last 3 months, and she's forgotten about the cancer diagnosis. But what does the outsider see versus what does the inside? And that I think would be my concern as to how can you can't, you know, it's almost need some brain scan or something, and then you're going into a whole new world of ethics. You know, when you experience that delirium, what does the healthcare professional see on the outside?
Like a merging of realities.
Oh,
During
you're coming off very robotic, Heidi.
Put it in the chat.
Yeah, so certainly, like, my experience pre-surgery is very different from my ICU experience of delirium. They are drastically different to the point that I would say that they're, how can they be the same thing? This heavy hallucinating, panic-stricken situation to this, I'll call it mild, but, you know, the slowly your thinking slowing, and I never felt like I was in danger. I never thought that I was being harmed, but I could slowly feel that I was no longer in charge of the ship. I was almost like another person inside my head while something else was running. So I was, you know, talking a lot of nonsense. I wasn't really acting like myself. I was being angry and other things. So even within my two experiences, they're not all that similar. So it's very tricky to say it, but that's the thing. You accumulate as much knowledge from the people that have suffered delirium as possible. You mix that with clinical experience, and maybe we find a solution that might work or help, or who knows. Questions?
Yes, I mean, I think it's a great, I like the measured approach, and I think that, you know, that how to know what's inside someone's mind is when the usual channels are not there. But for assessing pain in somebody with delirium, which is something I try and teach, old people with hip fracture often, and it's just that they're doing this, they're lying in bed frowning, and they might not be speaking very much, and when you try and talk to them, they might slightly open their eyes and sort of look at you, but then go back to this. And what I try and do then is slightly roll the affected leg. They've usually had an operation by then, and quite often somebody like that will just shout out in pain just with the slightest movement of their leg, and the frowning shows that they're in pain. It's quite basic, but it's not that they're concentrating on something. It's not that they're on, they're just lying there frowning, because a frown is Liz Sampson, who's a very active delirium researcher and professor of psychiatry in London. She's given some great lectures on delirium and pain, has a great understanding of it. And, using nonverbal means of communication, I think that could apply to fear as well, couldn't it? Unless somebody looks completely happy and looks at you in the eye and is like nodding and everything looks, of course, that could still mean that they're psychotic, but it might mean that they're not terrified, if they're able to smile and respond to an attempt to make somebody smile, with a joke or, some kind of an attempt at a conversation. I think maybe another rule would just be to, just as you're saying about your legend, just to keep assuming that somebody can hear you, and just say things that are pleasant and comforting and reassuring, and just say, hello, I'm Dr. So-and-so. Today is Wednesday, it's about 10 o'clock in the morning. I've just come to see how you're getting on. I'm not sure you're able to answer me, but I'm just going to say that you've been here for 3 or 4 days, blah, blah, blah. Do you know what I mean? Would you think that's helpful if it's done in a gentle, professional way, just to sort of there's a framework around your experience. Here's someone who knows what they're doing, who seems like a nice person and is treating you quite well. I mean, rather than somebody just sort of bustling around and fiddling with lines and, saying something that's nothing to do with you to their colleague about what they did last night. I mean, I imagine that the two experiences are different if you're able to hear. Is that fair to say? Yeah, just always assume that somebody with delirium can hear you, and assume that they're probably very disorientated and could do with a bit of reassurance and kindness. That would be a simple rule, wouldn't it?
I think treating people like humans always is positive. I think there's never a negative in speaking to someone as if they're fully aware, and just telling them what's happening, why you're doing it, things like that. I don't see how that can in any way be a negative. Mm-hmm. As far as I know, we don't know if that's helpful, but I would, from my singular 1 point experience, say that the person who spoke to me like a person was the good guy, and all of the rest of the people were the bad guy. So I think that it must be positive. I don't know what Rebecca and Louise think.
No, I agree. I see that from a different side now. I'm not really delirium related, but I volunteer on a stroke unit, and I've noticed that quite a lot. There's a real difference between, it doesn't matter if it's a physio, OT or a nurse or anyone. Some people will talk to a patient who's sort of quite sleepy or not quite with it, for want of a better word. That being rude, obviously. But there's definitely two differences between somebody who will talk to someone and in a way that they're not quite sure how to talk to that person because that person's like unresponsive. And then you get other people who will talk to that person and just have a conversation. And there's a real kind of difference between, I don't know whether people are unsure of what to do, because talking to a person who's not going to talk to you back, whether they think it makes a difference of how they talk to them or not, or, but there's a real kind of, there's a real sort of like difference between the two. And I think it feeds back, doesn't it? It's how you treat the patient, remembering all the time that they're just a human and they probably can hear what you're saying. It's just how they're interpreting it.
I mean, Heidi and Kimberly, it'd be great to get your, if Eleanor's still here, you know, I've had no training ever on how to talk to somebody with delirium, you know, other than to make a diagnosis. You know, it's just not part of the teaching of delirium, the routine part of the teaching. There's no training on how to interact with patients who are not in a normal state and able to interact back with you, apart from maybe talking somebody down who's aggressive. It's just not done, you know, in the UK, that to my knowledge, and it's, you know, I'm not aware of such things happening in a routine way. And if you think that maybe 20% of people in hospital have delirium or something like that, and many have dementia as well, it's obviously just a big gap, isn't it, in what we do, when these things are probably almost free. I mean, in terms of time, very cheap, you know, like just a few extra seconds, maybe, you know, quite easy to learn. And, you know, but there's no how to count. I think the word, you know, delirium counseling, maybe misinterpreted, because that might be like post-delirium, but we need to come up with a term for it, like, you know, interaction skills, you know, for how to interacting with people with delirium or cognitive impairment. Probably teach it in an hour, couldn't you? Just on a YouTube video with a little bit of some experiences, and, you know, hospitals could do their own practice sessions. I don't think it would be that hard. I mean, because most people in healthcare are quite reasonable people who spend all day talking to patients, you know, so they've got a lot of skills in general at speaking and interacting, quite confident at that usually. So just a question of steering people, isn't it?
Coming back to your question, Mark, I would say, and I don't know if it's the case for you two, that you can't say as a healthcare professional too many times what day it is, what time it is, because my memory was wiped. I mean, I wouldn't even say it was 5 minutes. You know, it may feel really patronising, really ridiculous as a healthcare professional to come in and say, hello, it's Wednesday morning, as you said, you know, it's 10 o'clock, I'm Dr. So-and-so, I'm just here to look at your wound, your scar, you know, I'm going to change your life. The next nurse could come back in and say very, very simple, you know, we're just going to clean your wound, I would have no clear timeline of that, no connection in those. I don't think you can reassure somebody too much. I don't know whether Lou and Mark would agree, but I don't think when you're in that critical state, I don't think you can.
I'm going to write that down. You can't reassure someone too much. I mean, that's a good rule, isn't it? And that's exactly what my friend said. She talked about fragmentation. You know, her brain or her experience was fragmented. You know, she couldn't make sense of it was. And in fact, Ravi Bhatt and Ken Rockwood wrote an article about more than 10 years ago, talking about fragmentation of experience being a key part of delirium. And as you say, you're just trying to help someone create a narrative that's, because I think what happens is that the brain, when it can't make sense of what's going on, it becomes scared, because it's a sort of sign that if you don't know what's about to happen, you can't predict it, then you become vigilant, don't you? It's like when you're in an airport and you don't know if your flight's been cancelled, you don't know if you're going to be able to fly home, especially if you're in a foreign country and things are all a bit different and weird. You know, that can be quite frightening, can't it? You know, if there's a storm or something and you're stuck, not that frightening, but a bit, you know, you're certainly not the same when you're in that position. You're quite vigilant. And I imagine that that's like that times 100, times 1,000, you know, that you're basically can't predict the future. You've got pain, you don't know, there's no one familiar coming to tell you what's going on. And, you know, your brain isn't working that well, so it can't piece together a narrative as to what's going on. So that's a really good, so you can't reassure someone enough. I'm going to write that down.
Yeah,
I think that's a really good.
A person can't be too orientated.
No.
They can't be too aware of what's going on.
No, I'd agree with that, Mark. And I like that fragmentation idea. I talk about being a jigsaw puzzle, so I likened it with the different specialities that I was under. So I had pre-surgery, and then oncology, and then ICU, and then cardiology. But I think it comes into that as well. It's you know, the brain's just so overwhelmed. It can't take the information in. It certainly can't put it together. There's no connection or timeline or logic. So there's snapshots of memory, but it doesn't make any sense.
Yeah, so I'm just going go back to one of the questions Kimberly asked. If I scroll back up, I know that rehab while you have delirium can be important in the management and treatment, but I'm concerned that me trying to get you to do physio OT will feed into your scary side of the delirium. Did you experience that? Or if something is well explained and kindness and compassion, does that mean it's less likely to be understood in a frightening experience? Do either of you want to start on that? Okay, me then. So I spoke at length with Dr. Corner, who's a physio, about this on my podcast, and we felt that a few things help. Obviously, speaking to the patient is a big part, just constantly speaking, giving them any choices that you can give back to them. So things like choice of music or other things like that. Just trying to give control back in a situation where they have very little control. And obviously doing physio not to your timetable, but to theirs. So if they've just went down for a nap, then it's not the best idea to interrupt it, because if you try to get someone to do anything, just a normal human, when you've just woke them up, it's not going to be good. It's not going to have positive outcomes. So just, yeah, again, centering everything around the patient is kind of what seems to be successful from what I've heard. If anyone else has a...
No, I agree. And again, to just kind of bring it back to what I'm doing now, I see that now. I'm shadowing occupational therapists, and in the afternoon, I can go with an OT into a patient's room and wake them up so the OT can do therapy. And it drives me insane, because this poor patient's probably had, getting over a stroke and just had probably quite a busy day, and then we pile in and an OT wants to do hand therapy or something, and the OT is, they see it from the point of view that it has to be done, and it has to be done today. And then my sort of point of view is, well, if the patient's resting and sleeping, why would you want to wake them up? Why can't you do it another time, or come back when it's better for them? So I agree with you, Mark. It just comes back, doesn't it, to the basics of like patient-centered care and all that sort of stuff, I think.
Yeah, so I've just been told that we've ran over, so I'm just wind it up now. So I want to thank Rebecca and Louise for being on the panel with me. It was great to have you here. I hope everybody found it useful. I've got a note of people to thank, so I'm just now going to run through some names. So I would like to thank Peter Noodle, Dr. Manny Krishnan, Professor Alistair McCulloch, Dr. Eleni Fixter, Mr. Chris Gaber, Dr. Roberta Castro, Dr. Heidi Lindroth, Dr. Rakesh Arora, Dr. Jim Rudolph, and Dr. Gideon Kaplan, who were all involved in organising all this and the 36 hours. So I'd like to thank all of them for inviting us and giving us the platform to speak on. And I would like to thank everybody that's watching for watching. And I really appreciate that yours are taking Delirium so seriously that you would allow us to have the platform to voice our views. Thank you very much.
I just want to say it's topsy-turvy, because we should be thanking you for sharing your incredibly moving and informative stories. And I think this has been in my top 5 most useful educational sessions I've ever had in my career, because it's done is it's brought together a lot of half-formed thoughts and a lot of things that I've thought about in the past. And it's just suddenly occurred to me, why don't we just teach this stuff as a routine and just make it something that's necessary? And we've got the platform, we built them, we've got the 3 big international associations, we've got big conferences, you know, and this is no longer icing on the cake. By the way, remember that people with delirium suffer a lot. This is now actually just part of delirium treatment. It needs to be built in. Counseling skills, how to talk to somebody, you know, how to assess someone's, you know, level of distress. And so watch the space, you know. I now declare that we're going to try and I'm sure Heidi agrees, and others, you know, on the professional side who've got with your help, you know, we will try and address this problem. So thank you very much. I think this has been a big deal, actually. Appreciate it a lot.
All right, if you're sounding like a robot, I'm going to turn off the recording, and thank you all so much. I completely agree. Let's do it.